All right, everyone, welcome back. I hope you enjoyed your lunch. All right, so welcome back to the More About MS program. I'm really excited to kick off this next panel with these incredible group here. So your panelists are psychologist Dr. Abbey Hughes, neurologist Dr. Huiam Mubarak, occupational therapist Hannah Richardson, speech-language pathologist Beth Wiggs, and our moderator is Dr. Meghan Beier, and we are going to be talking about the invisible symptoms of MS. And while there are many invisible symptoms today, we're specifically going to talk about fatigue, mood, and cognition. So please enjoy. Thank you.
Thanks, Stephanie. Oh, I don't know if you can see me. I'm a little too short. I'm going to move over. So again, thank you so much for being here. We have an awesome panel and a great discussion. We want this to be an interactive session, so I'm going to start that off by asking, who has ever heard the phrase, "But you look so good today"? Okay. Who has anyone had a friend, a coworker, a second cousin twice removed say, "But I have this person that I know who lives with MS and they did this thing and they're doing great"? Yeah? Okay. So we know that lots of people can observe us in different ways, and they form their own opinions about what's going on with us based on what they observe. But we know that a lot of the symptoms that we are experiencing are under the surface. Let me see. Oh, there we go. They're invisible, right? So the things that people see are those things like walking, falls, maybe some tremors, right? But the symptoms that can really impact our everyday lives are the things that many people don't see. If you're a care partner or a loved one of somebody living with MS, have you ever woken up and said, "I don't really know how my person is doing today"? Yeah? And it's hard to tell sometimes, and so that's what we're going to talk about today. Not only what is happening under the surface, learn more about those symptoms, but also what we can do about them. And we're going to hear from our panel how to address fatigue, mood changes, and cognitive changes from several different disciplines. So we're going to hear case studies today of how each of the professionals up here might address one of these invisible symptoms. And I just want to highlight, even though that we are looking at fatigue, mood challenges, and cognitive challenges, we know that these are only 3 of many invisible symptoms. So we would be here all afternoon if we were talking about all of the invisible symptoms. So if these 3 are not ones that are a big challenge for you, in those workshops that we have coming up right after this session, please feel free to bring up some of the other challenges that you're experiencing with our esteemed panel who's going to be part of those workshops. So with that, I am going to turn it over to Hannah.
Oh, yeah, that's me. I'm Hannah. Hi, good afternoon, everyone. I hope lunch was delicious. I didn't eat mine because I'm very nervous. I'm very, very excited to be up here with you all. And I'm going to talk just a little bit about fatigue. So I'm going to press that, and it works. Okay, so 90% of individuals with MS are functionally impacted by fatigue. So if the 10% of you are in this audience, just bear with us. And pay no mind. So what are some factors? Sleep, right? So having some issues with your sleep. Unrestfulness at night can really lead to poor brain rest, right? So discomfort, evening toileting, or even poor sleep hygiene. Those can impact your fatigue. Energy deficits. So what are your daily tasks? What supply of energy do you have, and what demands do you have throughout the day? That can impact your fatigue. Finally, what disease, the disease-related body temperature issues. So summer's coming up in Arizona. Is everybody here from Arizona? So I'm preaching to a lot of you guys as far as how the heat will impact your fatigue in the next months. Muscle fatigue, so deconditioning, or a mismatch between how much energy those muscles have and what you have to do with those muscles during the day. And finally, spasms, those also can cause fatigue with those muscles. Mood challenges, which we're gonna talk about specifically a little later on, depression, anxiety, day-to-day stressors, all of those things can be fatiguing on your brain. And then medication, there's a lot of beautiful information that Dr. Mubarak will talk about a little bit later in how medication can impact fatigue. Okay, so specifically we're gonna use a lovely term called lassitude. Who here is familiar with lassitude? Oh, okay. Well, lassitude it's like a MS-specific fatigue. So it's characterized by overwhelming tiredness. It starts in the morning and it progresses worse and worse. Did I see some nods? Like, oh my gosh, I have lassitude, yeah. So it progresses through the course of a day, and it's exacerbated even more by heat or humidity. The pathology of lassitude, it's not fully understood. Some believe maybe there's some central nervous stuff going on, or cellular dysfunction, or immune system. Where it comes from, I'm not as concerned with how it impacts our lovely people here with multiple sclerosis. And then not to forget take a moment to honor our caregivers with fatigue. So anybody here supporting a beautiful individual with multiple sclerosis? Yeah, so caregiver burnout, right? We've all heard of that. What are some things that are impacted there? Well, emotional, psychological stress. You also have physical exhaustion. You're taking on a lot more that you're supporting others through. And then relationship changes, how roles have shifted. Finally, financial and other social supports or stressors. Those can be fatiguing for caregivers. So we can't forget to talk about our tribes around us. Okay. All right, so identifying and managing those factors that disrupt sleep, thinking about bladder problems. How is your bladder impacting your ability to sleep wonderfully through the night for the restorative sleep your brain and body need? Pain. Having pain can make it uncomfortable to sleep, and depression and anxiety. The worries, the sitting there thinking of all the things you have to do or can't do. That'll impact your sleep. Spasms, which we talked about. And then there's primary sleep disturbances like sleep apnea or limb movements that can wake you up, and insomnia. In a moment, I'll have Dr. Mubarak come up and talk more about medication. But I want to talk just really quickly about managing that lassitude we talked about earlier. And I'm sure many of you have heard about the 4 Ps. Anybody in here heard about the 4 Ps of energy conservation? Yeah. So planning, pacing, prioritizing, and positioning. What do those 4 Ps actually mean? So planning daily and weekly, looking at your schedules, what appointments you need to fit in, what you have to get done throughout the day. Do you have work? Do you have family needs? And how does that all fit in? Plus scheduling some time for yourself. Finally, pacing, taking breaks. There's a 2-hour rule that's a really wonderful thing to follow. If you feel like you've exerted yourself or done a lot for the day, sit down, rest. After about 2 hours, if you're still feeling pretty tired, you probably overdid it, and you'll know better for planning in the future. Next, prioritizing. We have our haves, our needs, and our wants, the things we have to do, the things we need to do, and the things that we really want to do. And figuring out how to reconcile all of those and have energy at the end of the day to spend time with your family and do the other things and be able to go to the bathroom at night. Positioning. So sitting down or lying down can actually conserve 25% more energy than standing. So that should alert you to maybe thinking about the things you could potentially do sitting versus standing is a quick way to offer you more energy for the things that you want to do or you need to do. Exercise and physical activity, very important. We talked about supply and demand. What if we get our supply of energy up so that the demands aren't as taxing. So exercise is really wonderful in physical activity. Across the street, we heard so much research about the benefit of exercise in multiple sclerosis. And we'll talk more about that in our breakout sessions. Rotation of duties. So calling on and delegating things to other people. Use of adaptive equipment. I'm an occupational therapist, so I love my gadgets and toys. And if you have a hard time doing something, talk to an occupational therapist. They might have a way that you can conserve energy to do it safer or even better and maintain that independence. Next, I'll have Dr. Mubarak come up and talk a little bit about medication side effects.
Thank you, Hannah. That was so great. And I think one thing that, we always tend to look towards medications and things like that, but I think you saw even from the stretching earlier today, some of those lifestyle modifications that Hannah just talked about is that we don't always have to jump to a pharmaceutical agent first to treat something that is contributing to our fatigue. So, the stretching that we just did earlier, that all helps with keeping your muscles nice and relaxed and loose. There's things that you can use, such as like warm compresses or getting in a cold plunge, things like that. And I know sometimes there's sensitivity to temperature, so you have to know yourself and what really feels good for you. But I think one thing that you guys will take away from today's presentation is that everything is so individual. It's not one blanket thing or recommendation that you're gonna hear today that you can go and say, okay, I'm gonna do every single one of those things. You really have to know your body, know what works for you, and start there and kind of go slow with the changes that you introduce so that you can actually see what's effective for you before moving on to the next thing. I always kind of like to take it one step at a time when I'm seeing someone and addressing one thing at a time so we can peel away some of those layers that Hannah spoke about. And just briefly, I'll mention just a few things. As far as sleep, starting with sleep hygiene is always great, but when some of those conservative measures don't work, then you can look at some medications. There are some sleep aids that can be taken. Melatonin, of course, is a natural, more natural supplement that you can take, where I like to start. That doesn't have as many of the side effects as some of like the Z drugs that you might hear about, like Zolpidem, and things like that, where it may work really great at night for you, but then in the morning we're waking up groggy and we're waking up more tired and not able to get our day started. So you always want to kind of start low and slow when introducing new medications that you're going to be trying out for some of these symptoms that you feel with maybe lack of getting to sleep quickly or helping to stay asleep throughout the night. Again, with some of these, I would love to see more interdisciplinary care when it comes to that. And so we have amazing sleep medicine colleagues that can really walk you through those processes and really in detail spend time in your visit, not just talking about everything that you're going to, but just your sleep. So just imagine being able to go to your neurologist or your MS doctor and talking to them for sleep for an hour. And that's what you would be able to get in a sleep medicine consultation. There, we saw some studies across the way too about sleep apnea, whether it's obstructive sleep apnea or central sleep apnea that can be playing roles. And there's ongoing studies to see how we're seeing that affect our MS patients. And so hopefully in the near future, we'll have some more data on that and what's more effective. But treating those things can help as well. I heard you mention like urinary symptoms and getting up at night. And starting off again, non-pharmacologically, we have pelvic floor therapy that we can introduce, reducing things like increased water intake or liquids before going to bed. So kind of changing our behaviors a little bit and seeing if that is effective first before going into some of the medications like oxybutynin, where we can have some of those anticholinergic side effects of dry mouth and things like that that may be experienced. But what I do like to say is that not every single symptom is experienced by everyone. So if you have a friend that's tried one of these medications and it was like the worst thing that they've ever had, like, I don't know, a purple jelly bean, that's my least favorite. But, you just have to say, okay, maybe that didn't work for them, but I'm going to try it for myself because this is something that I'm really struggling with, and I've already tried several things and it's not worked for me. So really take it for yourself to do your own research, ask the questions that you need to from your provider, and see what works for you, because it might not work for someone else, but it might work for you. And then spasticity management. Some physicians will offer muscle relaxers or Botox, which works really great as far as it being a localized solution where you're not getting so many of those systemic side effects. And I know at BNI, sometimes it's offered in the office, but also we have our movement disorder colleagues that have more availability in making sure that we get you in for your Botox treatments as well. PM&R is another great resource that can handle kind of not just the Botox, but some pain elements as well that can be contributing to lack of sleep and contributing to fatigue throughout the day as well. There was a retrospective study back in 2014 that kind of looked at stimulants, things like modafinil, amantadine. And interestingly enough, compared to placebo, there was really no significant outcomes that came out where it was statistically significant, the difference between those stimulants and placebo. But anecdotally, people still will say, the modafinil is really working for me. It's allowing me to do more things or get through my day better. So again, that's kind of more of a nuanced conversation that you'll have with your providers. But that's just, I thought that was interesting that they did do that study before. And amantadine did show some modest improvement, but again, nothing that was statistically significant. So again, just kind of look at yourself and how you're feeling and make that the forefront, and start talking about maybe the first thing that's contributing or that you feel like is contributing the most, and start working at peeling those layers off during your visits, and really just make that a point to say, I want to make sure that we talk about this today. So even though you go through your routine checks, make sure that that most problematic part of some of your invisible symptoms are still heard during your visits.
Thank you both so much. So now we want to bring it into the real world and say, okay, all of these things that we just heard about, what does that look like in a real person living with MS? So I'm going to ask each of our team members up here to just give a 1 to 2 minute example of somebody that they maybe have seen in clinic, or an example of somebody that they might have seen for how they manage fatigue. Because we'll see that actually fatigue can be addressed by lots of different medical providers. And maybe by hearing from each of the members up here, you'll know maybe who would be the best fit for the challenges that you personally are experiencing. So I'm going to start back with Hannah. Can you share a quick kind of case study?
Yeah, can you guys hear me okay? Yeah, so when I talked about fatigue with my colleagues here, it brought to mind a gentleman who was in his 30s. He's a wheelchair user with primary progressive MS. And this gentleman is still striving to work, and he's a single father. So he's got a lot of demand during the day. So we put into perspective what he has to do, what he wants to do, and what he needs to do. So through collaborating with our comprehensive care team at Barrow, we were able to talk with our doctors about maybe some accommodations that his work could provide him, something for more rest breaks during the day, or seating options or computer options to help his day-to-day occupational practice. And then also collaborating with my physical therapy colleagues, and we worked together in improving his supply of muscle and endurance. So we did exercise programs for him. And then we worked on like OT-based things, positioning, how he can put his arms during the day, what stretches he can do, because he is a chair user and he does have to transport himself through work. And then ways to make it all feasible as a single father. So how can he combine some of those things that he's already doing with them, some of those things he wants to do? And we talked about with his girls doing exercises together. So he gets his exercise program in, and he gets that care time with his kids. So it was a really beautiful way to bring it all together.
Great examples. Now you'll hear from Dr. Hughes, Abbey, in a little bit about mood changes, but we're going to ask her about sleep. So can you give a quick example?
Sure. So in this example, a young gentleman in his early 30s, also working, with a history of depression and anxiety prior to MS. I think if there's one thing to come out of today, a lot of the invisible symptoms that we're talking about are correlated with one another. They overlap, and they make each other worse, and they can also make each other better. In his circumstance, he was presenting with some insomnia and anxiety and also severe fatigue. And the idea is that if we're not sleeping well, that can promote fatigue. However, even in the absence of sleep disturbance, people with MS can also experience fatigue. And so in his case, because he was so fatigued at the end of the workday, he'd come home, he'd go straight to bed around 7 p.m., but he would not be sleepy enough to actually fall asleep. And so he'd be spending quite a bit of time in the evening in bed trying to sleep, trying to get more hours of sleep, thinking that would help his fatigue. And instead, it ramped up his anxiety. It also then ramped up his depression because in the time he was spending in bed, he was away from his family, his kids. He'd missed the evening soccer games. He was not able to participate in those daily activities. So addressing the sleep issues behaviorally by trying to shift the clock, shifting when he's spending time in bed to align more with when he was actually able to sleep, then helped promote him getting better quality sleep when he was actually sleepy, not just the fatigue part. And in turn, when the sleep was matched with his bedtime, which we'll talk about more in our workshop as well, that helped improve the fatigue in the subsequent days and weeks.
Thanks so much. And Beth, I think you were going to tell us about a busy grandma.
I was, yeah. So when I think of fatigue, I think of cognitive fatigue. That's the first thing that comes to my mind. Cognitively, how a person is functioning, the demands that the MS is placing on cognitive functioning. And so when we started talking about fatigue, a particular woman came to my mind. She was retired, but she was the busiest grandmother I had ever met in my life. And she was caring for her grandchildren, her children, and many people in the neighborhood. So for her, by 5, 6 o'clock, she was done. She was cognitively, physically, mentally fatigued, and she didn't have time to do the things that she wanted to do. She didn't have the energy to do the things that she wanted to do. So what we ended up doing a lot with her was I had her fill out a fatigue chart. Every day, write down every single thing that you do and tell me what level of fatigue do you feel. And she came back to me the next week with a week's worth of sheets, and she had such an aha moment of, oh, I'm running myself into the ground every single day. I'm not planning, I'm not pacing, I'm not prioritizing what I'm doing. And so by the end of the day, I have nothing. And then I do that too many days in a row, and I need 2 or 3 days to recover. So by helping her to take advantage of those strategies of how to plan, how to prioritize, she was able to do so much more in her weeks and feel so much better and so much more successful and feel a lot less cognitive fatigue.
Okay, great. Thank you so much. And Dr. Mubarak, I think we are going to talk a little bit about somebody who's newly diagnosed. What should they be thinking about?
Yeah, a lot of the times, I mean, more recently even, having newly diagnosed, new mom who already had 2 toddlers in the house and now getting this new diagnosis. So there's already so many things contributing to the stressors and thinking about what's to come and kind of that unknown. And so she started to experience some more fatigue and felt like she was letting her family down or her children down by not being able to do all of the things that she was able to do before. And so we really had to kind of step back and say, okay, what are the things that you enjoy doing? And then how can we work that in and maybe plan and prioritize for you to keep doing the things that you enjoy doing with your kids, understanding that we need to give some grace to ourselves as well. You are going through so many new transitional changes, and then on top of that, having this new diagnosis, a life-changing diagnosis that you're now kind of putting into the programming of the day. So really working on just listing out, prioritizing, what's important, thinking about sleep hygiene and what she can get from help from her support team, because I think a lot of newly diagnosed patients don't want to become a burden as well, and just kind of taking away that stigma of asking for help. I think people, even without MS, have trouble asking for help. And so just focusing on the things that we do have control of and starting there, and then getting help for the things that may be a little bit out of our control with scheduling or pickups and drop-offs and things like that. So we take it one step at a time and really just assess what are the things that bring you joy, what are the things that you want to make sure you include in every day, in this particular case with her children, and then where are the areas that you can get some help that would make you feel like you're still able to have a full and fulfilling day.
Fantastic. And I heard in several of those answers, mood challenges, right? Depression, anxiety. If you're able and willing, has anybody experienced challenges with mood associated with your MS? Or if you're a care partner? Okay. Fantastic. So this is a very common challenge that many people living with MS, including care partners, experience. So I'm going to turn it over to Dr. Hughes to give us a little more information.
Well, first, thank you to those who raised their hands in this space, being willing to acknowledge this is such an important area in MS that for many, many years was understudied, under-recognized, and in many cases still is. There are significant mood changes that can occur in the context of MS. Is there a clicker? Okay. They can occur at any point in the disease course, and the base rate of mood disorders in general in the general population is upwards of 20% over the course of one's lifetime. And so the degree to which that may overlap with an MS diagnosis, either coincidentally or as a result of MS, both can be true in daily life and as you go through your lifespan. It can even occur as a first symptom because depression, mood concerns, anxiety, these originate in the brain, and with a central nervous system disorder like MS, changes in the brain can then elicit these mood changes, even without a history of these concerns. And as Dr. Beier mentioned, support partners can also experience these mood changes. There's been numerous studies that show that actually mood of someone with MS and their care partner or spouse or support partner, they can move together. Right? When you're both living with MS, right? Sometimes in Can-Do, we talk about it as it's not a me disease, it's a we disease. And that includes the wins, the losses, and the challenges with that. Mood changes can also occur directly by some of the neurologic and neuroimmune responses and the immune changes that occur, and as a side effect of some of the medications that are administered in the context of MS. It can be as a direct result of damage to the brain in the form of lesions, and it can also be a result of the immune system. If anyone has experienced having steroid treatment in the course of a relapse, right? Steroids can have a significant impact on mood, and fortunately, while short-lived, it may not cause a depressive episode by diagnosis, it can still drastically disrupt mood and sleep and increase anxiety over the course of the period and for about a month following the treatment. So these mood changes do matter. They can make other symptoms also worse. If you look at the diagnostic criteria for depression, right, there's sadness, there's loss of interest in activities. We think of those as the hallmark symptoms of depression. And along with that come a lot of the symptoms that we also consider part of the MS disease experience, right? Fatigue, sleep issues, changes in psychomotor function or psychomotor slowing, so changing how quickly your muscles move and react to stimuli. And importantly, in the final criteria, or one of the criteria within depression, are increased thoughts of self-harm and suicide. These are often not asked about in the context of a primary care appointment or sometimes in neurology appointments. And so if you are having thoughts around that, please do bring that to your attention of your PCP or your neurologist. It does matter, and importantly, it is treatable. There's some common mood changes that do occur in the context of MS, and one of them we might consider something as a normal grief process. There's normal sadness that occurs in the context of loss of function or any kind of major event. There can also be grief in what we would normally consider a positive event in life, like a wedding or some other event that we may consider positive. There can be a grief process that happens alongside of that because it's a change, right? When there's a major change, there's addition potentially of new, exciting, and positive things, and potentially a loss of something that was also meaningful. And so after an MS diagnosis or after a period of progression, right, there may be grief and loss within that, which is a normal response to loss. And it might not indicate that you have a depressive disorder. It might not indicate that it is meeting diagnostic criteria. And yet, we still need help with that. We still need support from care partners, from friends, for family members to get through those challenging times. And a mental health professional is someone who can help navigate whether those criteria are met, working with a neurologist and a psychiatrist to see whether potential medication options may be complementary to ongoing therapy. And so beyond the grief, if that grief process after a new diagnosis or after a progressive event or after a pseudo-exacerbation that we talked about earlier, if you notice that those feelings of feeling down, loss of interest in activities, if that's persisting for a prolonged period of time, again, that is treatable, and we want to elevate awareness to that. Depression is common in people with MS, about twice that of the general population over the course of the lifetime. So while I threw out that 20% number earlier, it's about 50% in the MS population. Anxiety is also very common, slightly less so than depression, and still warrants attention. And that anxiety can come in the form of health-related anxiety, right? Wondering, what's next, right? And the uncertainty that can drive. Sometimes that came even before an MS diagnosis. In working with a person who's had some general lifetime health-related anxiety, increased attention to various physical symptoms, and then in the context of an MS diagnosis, that anxiety was ramped up considerably. When we're not sleeping well, when we're fatigued, when we're under stress, these mental health symptoms can also then increase as well. And anxiety can present very differently across different individuals. So much like we talked about MS symptoms being different, anxiety can also be the case. So for some, anxiety may present as worry, like laying in bed at night, doing your checklists, worrying about what may happen in the next day, the next week, the next year. But for others, it may present more as irritability, being really short-tempered, having a short fuse. So keeping in mind that how anxiety may present may look different for different people. There can also be some physiologic sensations that come along with anxiety, like heart palpitations, changes in blood pressure, feeling lightheaded, like you might faint, right? And these physical symptoms, right, can often then trigger worse anxiety because you're worried something's happening with MS or another health condition you may have. Those feelings of terror, and then it also overlaps with cognitive symptoms. When we have that intensity of mental health symptoms, including depression or anxiety, it is absolutely going to affect our attention, right? Our ability to concentrate, which then it may present as fear of a memory concern, right? I can't remember things that I used to, when it may be a mood-driven attentional concern. So in terms of managing mood, again, I present that just to normalize that for those in the room who did raise their hand, who've had experienced some changes in their mood as a result of MS, there are ways to approach this that are evidence-based assessment procedures and treatments. So early and ongoing screening. By a show of hands, if you go to your primary care neurologist, raise your hand if more than half of the times you go, you're being asked about mood. That's a lot fewer hands than went up earlier. Okay. There's cognitive behavioral therapy and other forms of psychotherapy which directly address depression symptoms. CBT is an umbrella term for several different types of therapy. So if you have worked with a therapist and you've tried CBT, there may be other flavors or variations of that have been continued to be studied and published on in the MS population. And importantly, there's a behavioral component to this that is really critical that helps treat fatigue, the sleep disturbance, and some of the other physical symptoms that come along with depression. Medication can also be a component of that treatment, as well as physical activity and mental activation. Social support is also key to this. And again, having MS, particularly in current climate in our country with access to healthcare, the isolation can be significant. And so increased efforts such as today's program and other can-do programs that help bring people together to connect with one another and to engage and activate. These are the types of things that can help with the mood component of things. It's not a replacement for treatment, but it's an adjunct, right? It's a supportive enhancement to go along with mood disorder treatment. And that first step to managing mood issues is to acknowledge them in the first place, to track them and to discuss them with your health provider. So with that, I'll turn things back over to Meghan, and we can talk a little bit more about the impact of mood.
Thank you so much. Thank you so much, Abbey. So once again, we're going to hear about how mood changes might be addressed by each of our team members in a real case example. So again, I'm going to start with Hannah. I think you were going to talk about somebody with secondary progressive MS.
Yeah, so as an occupational therapist, I have like a unique opportunity to see a person fully for what they can bring physically, but also psychologically, mentally, cognitively, all those things to the table. And this is a young woman in her 40s who was struggling with severe depression. She also had some hand strength issues, upper body strength. She's also a chair user. Some of the things she was sort of grappling with was some role changes between her and her spouse and what that meant moving forward in their marriage. And she came to me with some severe depression and to the point where we couldn't exercise or do anything like that. So we talked about maybe starting through a reflect, a reignite, and a reclaim journey. So we reflected a little bit through occupational therapy by just challenging her to journal, maybe 1 to 2 words a night. Just anything she can muster, bad, good. It could be even just a purge of all the bad things she was feeling. So we allowed, like Dr. Mubarak talked about, having some self-compassion is really important. Like take a moment and grieve a little bit. And then we talked about reigniting. What does she want to do? So through occupational therapy, we talked about building routines. So again, going back to the haves, the wants, and the needs. What are the things you have to do, you want to do, and you need to do? So we built an actual routine, an exercise, and some of those really wonderful things were on the routine. And finally, we reclaimed the things that she wants to do in the future. And we built a beautiful vision board for her. So some sneaky occupational therapy work, having her cut out things and glue things for the hand strengthening. And it just gave her something tangible to leave with and to remember that there's still a journey. And Dr. Robers talked about it earlier about the sun shining, the sun coming up. And that's what I hoped that my therapy helped her with.
Fantastic. That's such a great model. Finances can be a source of stress for a lot of us. So Dr. Hughes, can you talk a little bit about that?
Sure. I'll speak about an older male in his early 60s who retired early due to MS, and he loved his job. He worked in a sales job and was going door to door, company to company throughout his career, and really prided himself on being the provider for his family. And because of the retirement with MS, there was a significant loss of identity in that, without a replacement activity at the time that happened over a fairly brief period. And so when these stressful events happen, it not only changes that access to daily activities, the social engagement that he was getting daily, but also from a financial standpoint, going on disability was a significant financial hit. So all of those pieces together, the loss of the financial income that then changed the priorities of their family, the degree that they could go travel together, the need for one of his older children to work more hours in order to make up family income. All these stressors together, right? They in and of themselves do not cause depression, but they can contribute to the overall picture of those mood changes and that loss of meaningful activity. So through psychotherapy, both with him and with his family members, we started to break down what are some actionable, small, SMART goals that could help increase that activation and increase that participation in daily activities that didn't have a large financial footprint and could increase that efficacy. It didn't replace, right, that job or that income, but it started to increase that sense of self-efficacy and work towards that so that it didn't have as much of an impact on daily function.
Great, thank you so much. And Beth, can you share about a working parent?
Yeah, so I had a woman in her 40s. She was a working parent full time, and she was trying to do it all for everyone all the time. And like Dr. Hughes touched on, feeling a lot of anxiety and some feelings of depression about losing her ability to do it all and feeling like she couldn't do it all. And if she didn't do it all, then she wasn't a good mom, she wasn't a good wife, she wasn't a good nurse. So she needed a little bit of help and structure to help see all the things that she was doing and that she could do. So we worked a lot on using something called an Eisenhower matrix to help her organize and determine things that were urgent and important, things that were important but not necessarily urgent, and things that she could delegate to other people. And by helping to know how to delegate, that really lifted a lot of things off of her plate, and she felt like she was making a much more significant contribution to her family again, and that really helped with her mood and overall sense of self.
Great. And we've heard about some behavioral strategies here, but let's talk to Dr. Mubarak about medication.
Yes, so thank you, Abbey, for that great example about how therapy and the medications can really work together for someone's benefit. I think one thing that I see a lot of patients struggling with is just medication overload and having one more pill, one more thing that they have on their to-do list. But sometimes that one other addition is something that will make a significant impact on your quality of life on the day-to-day basis. So I think in conjunction with therapy, there's a lot of really great treatments that can be added as an adjunct, and some of them to consider. We have like our SSRIs, like fluoxetine, sertraline. I'm sure you guys have heard some of these names before. Things to kind of look out for. Sometimes they can cause some GI upset and things like that. Then there's SNRIs, or serotonin norepinephrine reuptake inhibitors. And sometimes this is great because if you are dealing with neuropathic pain as well, it can maybe reduce your medications, because we can use things like duloxetine for neuropathic pain. We can use it for headache. We can also use it for mood stabilization. So maybe opening up that conversation about mood can actually reduce the amount of medications that we're on by choosing something that's effective for all of them. There's other medications as well. And I think one of the things to think about is that when you're asking for help with your mood, and maybe an addition of a supportive medication to help you get through a difficult time, is taking away that stigma that I'm weak because I need another medication. And that's not the case. I think the bravest and most courageous people are the ones that open the door to say, I've done everything that I can do on my own. I think I need some more assistance. And then we can kind of go from there and navigate who the right team and support team is for you with your therapist, monitoring the medications, making sure that they're not causing more harm than good. And that's always important. So knowing the safety profiles of those medications and really asking your providers and prescribers, what are the risks of this medication? What do I need to look out for, so that you can have control of saying, hey, I've noticed this more. I need to maybe talk about this and switch to something else. And having someone take that burden of, is this working, not working, while you're seeing them long-term in the clinic, can really help kind of take some of that burden away of, is this the right thing for me to do? And they'll kind of walk you through those steps and walk you through that process. So I kind of just wanted to overall say that although we try to avoid the polypharmacy in the long run, and you'll hear me mention that later on, I think it's really important to know that there are some medications that are very good adjunct to some of these behavioral changes that we're making for ourselves on the day-to-day basis.
Fantastic. Thank you all. So we're going to round out this series talking about cognitive challenges. So I'm going to turn it over to Beth to give us a little background information.
Thank you, everybody. Okay, so we are going to be talking about cognition. in the setting of MS, definitely an invisible symptom, but a very common symptom. So 65% or more of people with multiple sclerosis will experience cognitive symptoms at some point during their journey. And for a lot of people, some of these symptoms can start even before a diagnosis starts and gets received. And once the diagnosis is received, then they're like, oh, that's why I was feeling that brain fog. That's why I was having challenges with things. I've been telling people I can't find the word that I want to say, and I'm falling out of conversation. And it's important to note that cognitive changes and physical changes can happen independent of one another. Just because a person has a physical impairment doesn't necessarily mean there'll be a cognitive impairment, and same vice versa. But it's important to look at cognitive symptoms consistently throughout your MS journey, even if there aren't any physical symptoms that you're experiencing. Most commonly with MS, these are the symptoms that we see in terms of cognition. Number one is processing speed challenges. Processing speed in terms of your ability to take information in, deal with it, manage it, and then also your ability to use that information and do something with it. Things like processing speed and attention can really have big domino effects and can really affect other cognitive areas. So if you're not able to be focused, pay attention, multitask, use your working memory, process information, then it's hard to do things like make a new memory. It's hard to make a decision of what to do. It can be challenging to find your words in conversation. Your brain just doesn't feel like it can quite keep up with the pace of conversation. So these are the things that we see most often in terms of cognition, and these are the things that we address a lot of the times in therapy. It's important, like I said earlier, to be aware of your cognitive symptoms and constantly be evaluating them, screening them with your neurologist and primary care partners. And then if on a screening or if you start noticing some changes to your cognition, a more formal cognitive evaluation might be warranted. Different professionals can complete cognitive evaluations. Speech-language pathologists like myself, occupational therapists, psychologists, neuropsychologists, we all evaluate cognitive functioning. Our toolbox, it looks a little bit different. The assessments that we do are a bit different. But the goal in the end is always to see exactly how is it that the brain is functioning, where are the breakdowns occurring, and ultimately what can we do about it. For things like disability, formal neuropsychology evaluation is required, much longer, much more in depth. If anybody's had a neuropsychology evaluation, you know it's 4 hours of very long testing. Helpful, very detailed information, but long. But then if any difficulties are noted in any of those assessments, usually it's the speech pathologist that provides the cognitive rehabilitation. So our evaluations are helpful in identifying exactly what is it that is going on, where is the breakdown occurring. Some people say my memory's terrible, I can't remember anything. And then we do an assessment, we realize your memory actually works pretty good. It's your attention and your processing that's the problem. So let's work on that. And doing that assessment helps us to really personalize therapy approaches. Our goal is always to help that person with MS to live their best life possible. So we identify strategies, we figure out tools to use, and by working together, we here in our program, we work together with our OT and PT partners. And if I'm working with someone and I start to identify as we're talking about some challenges they're having, hey, I think this is something that my friend Hannah can really help you with, or I think maybe seeing a nutritionist, a dietitian can really help you facilitate that part of your your abilities as well. Okay.
Okay, thanks so much. Hannah, I'm going to ask you to talk a little bit about somebody who was having trouble with cooking.
Oh, she had trouble with a little more than cooking, but that was one of the things we worked on. So this, when we talked about cognition, it brought to mind a 60-year-old woman, recently retired. She lives alone, doesn't have a lot of family support. She was struggling a lot with cognition. So I was lucky enough, and we're lucky enough at Barrow to have a comprehensive MS program where we can call on other disciplines to help. So lucky for me, I had tailed off of Beth here, who had already started this woman on her organization journey. So with like a planner and a journal, things to help compensate for the cognitive, the cognitive issues going on with her. So specifically, what I worked on was first of all, it takes a village. So sometimes somebody reminds you, but it's helpful if more than one person reminds you. To use those things. So we worked a lot on task shifting, her ability to go between tasks at home, like making sure that you're checking on the thing that you just put in the oven after you come back from folding the laundry. Also planning what she had to do through the day. In session, what we did is we simulated some of these tasks. So I had her do a full circuit where every time the timer rang, if it was one chime, she had to go do this. If it was another chime, she had to do that. And it really, all that really solidified for her was that she could do it. And I think the hard thing for some people struggling with cognition is, I just have a bad memory and that's just the way it's gonna be. But to be able to empower somebody in a session and remind them, wow, you did really, really well with that. She was able to go home and do homework and come back and tell me about this beautiful sheet pan meal she cooked. So that was really rewarding as an occupational therapist.
Oh, fantastic example. Abbey, I want you to talk a little bit about how grief can impact cognitive functioning. We know that emotions can have a big impact on our thinking skills.
Sure. So I'll speak about a 50-year-old woman who lost her partner very suddenly and in a very unexpected way. And again, I will say normal grief process, meaning devastating grief process, in that was also accompanied by her partner being her primary care partner, who did a lot of the executive function tasks over the course of the week. So planning meals, driving to medical appointments, managing day-to-day activities. And so overnight, this woman needed to take on a lot of those executive function skills that were not a strong suit given the history of MS and the progression of the disease. So we were working both through the mood and the grief process along with some executive function strategies hand in hand, and identifying who else within her support network could take on some of those strategies. So while offering psychotherapy from a mood and grief standpoint, we were also infusing some executive function strategies. As an example, she had a very regular schedule, but if she were to perform those same activities that takes her longer to do, even to go from her bedroom to the kitchen and then to the bathroom and then back to the bedroom to do things in the same order that she used to do them, that was not going to work for her because she wasn't as efficient. She couldn't do them as quickly. And so we talked about rearranging her schedule to try to group things in the day to certain parts of the house. So she's not going back and forth, but really only transferring a certain number of times per day. That also helped with the fatigue management. And again, when we're addressing fatigue and addressing the overwhelm of the cognitive load, that also led to improvements in mood as well.
Thank you. And Beth, can you please share about somebody who was fearful about losing their job?
Yeah, I had a man who was newly diagnosed, but he was primarily experiencing cognitive symptoms. And he was concerned about losing his job because in his most recent job performance reviews, he got poor marks and kind of warnings from his bosses about his performance. He was turning in projects late, he was making mistakes, he was having a hard time tracking and following what was being said in meetings, so he was forgetting the things that were being said to him. So he was very concerned about him losing his job, especially he was the primary financial provider for his family. So we worked a lot on identifying strategies that he could use to facilitate his memory, organization, planning, prioritizing, so that he could get through his day more efficiently, recall the things that he had been told, things that he's done, and plan out the activities that he needed to do. And happily, by the end of his plan of care, he had just had his next performance review, and he got really great remarks and didn't lose his job. So that was great.
That's fantastic. Dr. Mubarak, can you please share about how you address cognitive challenges?
Yeah, I think early on, especially with someone who may be newly diagnosed, it's really important to kind of help them build that care team with a lot of people that are sitting on the stage here today, is really plugging them into people that know, how to make a positive impact on their quality of life. There are many people living with cognitive challenges outside of even the MS space that still live very full, fulfilling, and successful lives with using the tools that are there and resources that are there for them. So I think getting the care team assembled so that patients are aware of who to contact for different things, or even if they're unsure of who to contact, kind of using our office as a resource and asking those questions to our care coordinators, to our nurses, and being able to get direction and introducing them to what occupational therapy really is. I think as a trainee, I rotated with some of the team here just to understand what we're offering and be able to really articulate that better to people during appointments, because some people might say, well, I don't really think I need the physical therapy or occupational therapy. I'm still able to do the things that I want to do, but cognitively I just feel a little slower, not understanding the big benefit that can come from a visit with an occupational therapist, a speech pathologist, or a therapist as well. So really putting that team together is really important early on. But I think even as we move forward, we have the privilege of seeing people long term. And so when things change, we have to kind of adapt and see what new assessments we need to do. If we have baseline assessments, that's always great with some of the standardized things that Abbey mentioned earlier, so that we can see, has your mood changed over time? Have we seen some changes in certain areas of your cognitive function that maybe we can hone in on and get you feeling a little bit better by addressing specific goals that you have? And so I think handling cognition changes over time with the person, but I think having those open conversations of how we can help and meet you where you're at is really important.
Wonderful. So thank you so much to the team for talking about all of these different symptoms and different strategies that each of you use for the invisible symptoms that we covered today. I hope what you've gained from today is that there are many team members that can help, and there are lots of different ways that each of these team members can help to support and hopefully make a difference in some of these invisible symptoms. So what we'd like to say is, please continue talking to your medical team. Bring up some of these challenges that we maybe talked about today in the workshops that we're going to go to next. And with that, I'm going to turn it back over to Stephanie.
Thank you all. So we're going to do a couple of things. I'm going to give you instructions for the workshop before we break, but we recognize that there was a lot of good stuff that we just went over. So if anybody wants to stay behind for about 5 minutes of Q&A, please do so. If you need a break, please take it. But before you leave, a couple of things. So we're going to take a 15-minute break. When we come back, there's going to be 3 different workshops. The first workshop, I believe, do we have them listed? Yeah. So the first workshop is going to be how to reduce your risk of falls, and that's with physical therapist Dr. Anna Colley, physical therapist Dr. Jilly McDonald, occupational therapist Hannah Richardson, and this will be in the Deer Valley room. And then achieving restorative sleep with neurologist Rena Abraham and psychologist Dr. Abbey Hughes, and that's going to be in Paradise Valley. And then a care partner, exclusively for care partners. We ask all of you that are care partners here today, please join us for a special session just for you. And that's how to survive and thrive as a care partner. And that's with neuropsychologist Dr. Meghan Beier and neurologist Dr. Huiam. Mubarak. I had it first, Mubarak. And that's going to be in the North Mountain room. So you're going to go out these back doors and to the right, and the staff will help direct you there. Also, we're going to have you come back into this room at 3:15, and from 3:15 to 3:30, we're going to do some key takeaways. And I'm going to be asking you to take the surveys out of your packet and fill them out for us. This is very important. This is how we improve our programs year to year. So I will remind you at least 2 more times to finish the surveys. So if you need a break, take a break, move to those breakout rooms, and we're going to have a mic going around the room and ask our panelists some questions. If you have any, please raise your hand. That's great.
Could you repeat the rooms one more time?
Yes. Is there? There's not.
We're just taking questions. Great.
Yeah.
We're just second.
Say, is it in this?
Lady in the white shirt.
Right there.
Question. Okay.
I was newly diagnosed in January, and I'm about to turn 45. And the hot topic right now at my age is perimenopause and menopause. And every single one of these also checks that box. So how do you, this is a loaded question, how do you determine whether or not all of these issues are perimenopause or menopause or MS? And are they related? And what do I do about it?
Anybody want to start? I can start with that. So there's always things, and that's the thing that's interesting about MS is that you're still a whole person that goes through, what everyone else goes through that does not have this diagnosis, right? So I think that conversation comes closely with the evaluations that you have with your primary care doctor to start, and just explaining to them the symptoms that you feel, knowing well and advocating for yourself, saying, I know I have multiple sclerosis, but I'm also concerned about these symptoms that may be being caused by some of these other things that I'm feeling, and having an open conversation with them, letting them do their evaluation, and then also making it an open communication between us and your primary care doctor, where you're not having to share the full story or share the full evaluation, and that burden of communication where, we can send messages to each other, our notes, our evaluations. And once some of those boxes are checked, if your hormone levels are looking good, or, they've really evaluated thoroughly that medical concern outside of the neurology space, then we can work with you on a step-by-step kind of peeling back the layers of how you're feeling, and working with that evaluation from that standpoint.
Thank you.
Yeah.
I just also wanted to mention that from a neuropsychology or testing perspective, many of the tests that are used by neuropsychologists as well as speech pathologists and occupational therapists are normed in a way that we are comparing you to other women who are the same age and have the same amount of education. So a lot of times we're able to say, like, in comparison to this group of women who are in their 40s to 40 to 45, are you performing about the same, or is there a difference? And so that often can help us to sort of say, well, okay, many people in this group would probably be going through similar life circumstances. So it's more likely than not that this is coming from MS as opposed to something else. But I would also, as a testing psychologist, I would also refer back to the medical team to rule out any other underlying factors that might be contributing.
Okay. And if there are no other questions, just pick one of 3. So Falls, again, that's in Deer Valley. Sleep is going to be in Paradise Valley. And Care Partners are going to be in the North Mountain room. And we will see you back in this room at 3:15. Thank you.